Good morning to all the viewers of Complex Coronary Live Case Series, which is entering to fourth year, starting today. And I'm very excited to welcome all of you and start a new chapter in this series, that is affiliation with the American College of Cardiology. Today, as you will see here, that we have the excellent faculty which are supported this live webcast, along with Mount Sinai Medical Center President Wayne Keithley, and I'll ask all of them to make a little statement, some note about what the live series has been. As many of you know, that we started this journey back in July of 2009, we started just at Mount Sinai home production, you could say, which then mushroomed to HMP communication and then heart.org, which has led to now to this best of its best. That is the concept of the global teaching that has been the focus of this series, and it has been rightly dubbed as the master class in interventional technique. Many of viewers actually have commented on the heart.org as well as our CCC Live website that people will be envious of sharing the tips and tricks to have a success. As you know that in United States, Mount Sinai Cath Lab and interventional cardiology has the highest number with the lowest complication. And it all boils down to minute details and the protocols what we exercise in our Cath Lab. And it will be my great pleasure that anyone globally can adopt that and get the similar result what we get at Mount Sinai. So again, the focus will be for months to come, emphasizing on the procedural technique, and now with the collaboration with American College of Cardiology, with their staff, and of course their depth of marketing and reaching the global viewers will enhance this mission of educational teaching worldwide. And of course, we all ask everybody that keep giving us suggestions how to improve the overall our series and any special cases which anyone wants. With that note, I'll ask each of the staff here to make a little comment, starting with Dr. Keeney, Director of the Cath Lab, and as you see, those who have seen, that has been the main operator for all the live series cases and really makes the tip and tricks of the field.
Good morning, everybody. Welcome to New York and Mount Sinai to watch this series of cases where we focus mostly on technical tips, avoid complication in complex coronary cases.
Okay, now Wayne Keithley, President of Mount Sinai Medical Center and Hospital.
Good morning. Thank you, Dr. Sharma. Congratulations on our fourth broadcast. I want to welcome all of the viewers and, of course, the American College for joining us. Thank you. This is a great occasion for us. This is an important part of our outreach program and educational program, which have been key pillars of Mount Sinai Heart from its inception. And I think in addition to the success of this morning's broadcast, we have some other breaking news which I'd like to share with Dr. Sharma. Congratulations. U.S. News has ranked us in the top 10 of cardiovascular programs in the country.
Fantastic.
And once again, Mount Sinai Hospital is on the honor roll list, and I think that's in no small part to the success of Mount Sinai Heart and the faculty and staff who work so hard to make that possible. Thank you and welcome.
Great. Now, Dr. Spencer King, which everyone knows.
Well, I think this is a really important initiative. You've done a great job in the past, but the College of Cardiology, of course, has a mission of education, and the opportunity to do live demonstration, of course, we've had for many, many years, but now we have the opportunity for people to see it on their own time. And so this is, I think, a tremendous thing you're doing, and I congratulate the college for getting involved here and teaming up with you to spread the word around the world. There are tremendous opportunities worldwide for education and improvement, not only from here to there, but from there to here. So once again, congratulations.
Fantastic. Great words. And the man behind who brought this relationship is Jagat Narula. He actually brought but our ACC organizers to look at our webcast, and they were highly impressed, and goes with the mission, as Dr. Spencer pointed out, is the education, global education, and credible. That's not industry biased. Always, actually, our yearly symposium, when people fill up that any of the presentation, was it industry biased? And for last 10, 12 years, it has been anywhere between 98 to 100% of the people who come to our live symposium in June have said it was not biased by the industry. So this clearly will be the focus that really tell the real stuff. Without, of course, you present the latest data and we keep changing based on the available results. But the purpose will be the present it in a pure form and clearly with some tainting from our own practice, that how we use it. And of course, Jagat being here, and he started this a few months ago, which had led to this final our affiliation with ACC. Jagat, thank you for that.
Thank you, Dr. Sharma, and congratulations to you for your continued success, and congratulations to Wayne for bringing the cardiology to the level that we are today. Thanks for all your support. And essentially, I think more than anything, I really feel that the best part is the new era that we are starting in terms of our collaboration with the American College of Cardiology, the mission of educational, educational drive, but most importantly, our mission of going global, which has been the most important thing that Bill Zogby, our new president, has been proposing in these days, that we have got to go global. And I don't think that there could be anything better than what Dr. Sharma is doing in the field of interventional cardiology. So congratulations, and I look forward to successful years ahead. Thank you.
Great. Now, Josh Dangus is here as our Director of Cath Lab Innovation, and has been a great addition, both George as well as Roxana, to our interventional research front, and we started seeing the output and publications of all the hard work which has been which is taking place now.
I'd like to also thank Dr. Sharma, Dr. Keeney, and Wayne Keithley for the organization of the Cath Lab and the Medical Center. And clearly, I want to add, not repeating the previous, that in addition to the congratulations and the comments by Dr. King and Dr. Narula, who both editors of two journals, JACC Cardiovascular Interventions and the JACC Imaging. This global education is very key, and in these purposes, the college also started an outreach with global cardiovascular news as well as the cardiovascular interventional news this year. And I'm happy to announce that as the editor of the latter journal, the Cardiovascular Interventional News, we're going to be very happy to also publish on a periodic fashion not only the subject but the take-home messages of this symposium, both in the printed form as well as in the electronic form of the journal, again to enhance more communications and more discussions about the subjects that are always very key, because the theory is in the symposia, but how we practice medicine belongs to the hospital and the medical centers.
Great. And now I'll ask Ron Ensign from college.
Terrific. Well, we couldn't be happier to have you on board and in broadcasting on cardiosource.org. This has been a pleasure to put together and have a part in this. Congratulations on your ranking. We're very proud about that as well. We look forward to growing the program even further through CardioSource Interventional News and some other avenues, and we look forward to the ongoing excellent programs as they've been in the past going forward in the future. So welcome, and we're excited about having you with us.
Thank you. Thank you. Great. And of course now Samir, which has been the true supporter and the key part of this success, doing moderation uninterrupted for last 36, starting with the 37, and flies just for this a few hours of third Tuesday morning.
Samin, looks like everything we have done in the last 36 months has been for this moment. I'm absolutely delighted with this new affiliation. I think this is not only going to further expand our global impact, but even lend a lot of academic credibility. In addition, we are looking at aggressively starting a CME component to it, hopefully, which will help us capture new frontiers. Beyond that, nothing changes. It is the same excellent format which you've been watching every time. It is going to be the steadfasted non-conflict of interest cases, and come and watch us. You are guaranteed a most unique and complex coronary intervention. Samin, congratulations again.
Thank you, thank you. And now we'll get ready. We, as you can see, from Sinai point of view, we're missing Dr. Valentin Fuster, who is on vacation leave, which is he takes actually from mid-July to mid-August, and goes, I think, becomes in best shape. Goes mountain hiking or bicycling, and so Tour de France, and excellent. So therefore, this could not be, but I expect him to be part of it next month. Will jog me. With that note, I really start. Anu should be ready in the Cath lab with a case presentation, and we'll get into the Cath lab, myself and Dr. King, in few minutes, and Samir takes his center stage and facilitate through this case. Okay.
Good morning, everybody. Is Samir Mehta? Yes. Are we live now? Yes. Good. Yes. You can see the slide of the case. If you see, is a 65-year-old male who presented actually middle of May with dyspnea and angina class 2. But he had a coronary CTA which revealed that he had 3 vessel disease and a calcium score greater than 1000. He then had a stress test which showed mostly moderate size lateral wall ischemia, and after that he was referred for cardiac cath, which I will show you shortly, which showed that he had extensive 3 vessel disease with a syntax score of 30, normal LV function. As a part of Mount Sinai Cath lab routine, what we do is any patients with a syntax score above 23, intermediate syntax score, we have a heart team discussion. The patient was taken off the table, and actually discussion of coronary artery bypass surgery was done with in the presence of a surgeon. He refused and then came back for the PCI here. His medication, as you see, he was is on good medical therapy. Can we go to the next slide? Press the go. Yeah. And can we show the angiogram now? Yeah. You can see it. Yeah. So it's a short left main. If you see there, that was the totally occluded circ which he had, which was attempted last time, but you can see it. There is a channel created this time. There is a large OM before the distal circ or the OM2, which was a branching vessel, and this is his left anterior descending, which you can see there is 70 to 80% moderate calcium before the first septal. There is a moderate size diag before the first septal. Then after the second diag, which is technically becomes a distal LAD, you see another long 70% disease. This is a LV function normal, and right coronary artery had a disease which already stented, and the stent is patent. So today he is here for the PCI of the LAD, which would be FFR guided, since it is 2 lesions we have, again moderate calcific disease. We'll do an FFR and then make a decision which lesion to be intervened.
Anu, are you planning to do something for the circumflex also?
Now, before we did this angiogram, that was not in our mind, but now having seen this vessel, which is what we normally see, that when you do total occlusion, that you are able to get through the true total occlusion, but if you are not able to get into the lumen, distally what we call as you have created a channel and distally you are not able to get into the lumen, multiple dissection channel, usually when they come back there is a channel created which exactly what we see, and in this situation we may be able to get into the true lumen of the circumflex.
Yes, that's what it looks like here, and clearly the appearance of it was different last time.
Yeah, it was a the total occlusion starting just after the OM, I would say at least between about 25 millimeter long total occlusion till you start seeing the large bifurcating OM2 was totally occluded. And you see there where we are trying to get into the lumen, the large branch, there is some dissection still there. That is where dissection created trying to get into the true lumen last time. You can still see it now.
Wonderful. In the meantime, we welcome our viewers in China, Niha, and hopefully you're able to listen to our simultaneous webcast. Please keep sending us your feedback, your questions, and we'll try to address those today. Samin, good morning, and congratulations first of all on this wonderful ranking from the US World Report.
Absolutely. Absolutely, that comes right timing. I mean, you can't have a better than that. That, as you know, that 4 years ago, we were not in first 50, then 42, then 18, and 13, 11, and now 10. So clearly, we are doing something good.
That is absolutely remarkable. Samin, in the brief presentation we had before, some of the reasons were indicated about the benefits of joining with the American College. What do you see are the main reasons? What would be the advantage? How does this take the program forward?
Well, with the global reach of the college, we expect that many, many more countries will become part of this our mission, and that is the global education right at their home and able to interact. Now we know that there are a lot of live conferences take place, people can go to the videos and so, but their ability to do it and ask questions and interact is one of its kind. I saw that actually there is another endovascular started from Germany, and second actually we started our endovascular series from Mount Sinai also. But key is that by collaborating with ACC, with their multiple branches and satellite centers, and so we expect to reach to more and higher number of audiences.
Samin, has Dr. King joined you?
Yeah, Dr. King is just entering in, he's putting the LAD on so that we go through the with this case once again for 1 minute and start the process, and then I present my two important topics of today, and then we take it from there. But yes, clearly the as you see that our this complex cases live series started just very small with the 250 and plus viewers which we used to have. So before we get in, and now you can see about 5,000 to 6,000 viewers. This is actually the computer hits. There could be more than one person sitting in front of the computer, and I know that at least 12, 13 of the Cath labs it's considered as a journal club, and we get input from many of those our junior attending and fellows, and so it has been a global reach with the 117 countries, and we expect that with our affiliation now with the American College of Cardiology, this will go even further.
Samin, also the feedback which we've been getting from so many of you who write to us has always been the request to add a CME component, which I think will be another major addition.
And that actually comes with the college, and we tried to do this in the past, were unsuccessful. But what will start, that the pattern will remain the same, but we started now the 5 cases. The idea is that those who attend it for this an hour and answer those 5 questions, and how the college CardioSource will come up with some way that to get a credit for one credit, 1 hour credit, CME credit, whether it's going to be done now or a little later, that is still being decided. But what I have added today, that at end of the presentation I have 5 questions which need to be answered, and they're simple, related to the presentation topic and so. And now actually Dr. Spencer King has come in and joined us. So we'll go through this case. I just wanted to show to Dr. Yeah.
Samin, in the meantime, I am delighted to welcome to our viewers Dr. King. It is absolutely the perfect person to have to begin our new partnership with the American College of Cardiology. As most of you know, Dr. King really does not need any introduction. He is probably one of our best cardiology teachers and mentors. He is a mighty scholar, a prolific researcher, a brilliant innovator, and an exceptional interventional cardiologist. Spencer, don't want to embarrass myself or you, but you are clearly the beacon which illuminates interventional cardiology.
Absolutely.
We find your signature on every PCI guideline, and more recently, I am very intrigued about a lot of your innovative work with the appropriateness criteria, and with this initiative you have probably become a voice of reason and the conscience of the interventional cardiologist. I see that as one of the biggest issues confronting interventional cardiologists over the next decade, and hopefully today we'll use your wisdom to answer some of their concerns. Welcome to the webcast, and I could not have personally hoped for a better person from the college than you, Spencer.
100% agree, and they could not have a better start of our this ACC series, and really, which is at the point of discussion in the country, as we all know, that appropriateness, that PCI, doing a PCI is fine. Everybody does it, can do it very well with a very low complication, but is it needed? Is it appropriate? Is it going to change patients' lifestyle in terms of symptoms, or will prolong life, decrease myocardial infarction? That actually really has come to the crossroad with so much uncertainty for people who are not well versed with the subject, are actually not doing. I can tell you, Dr. King, that I see few cases which come to me for review, and I would say, why would this angioplasty not be done? Everyone makes it sense, 90% lesion, but they're concerned about appropriateness, not appropriateness, because they're not aware of it. And clearly, you being the editor of the JACC intervention and trying to convey this message to the global audience and practicing cardiologists everywhere. This is a more issue for United States compared to outside, because I can tell you in India, nobody will get a PCI unless they have been on multiple medical therapy and waited a few weeks.
And plus called you at 3 in the night to ask what you want to do.
Yeah, let me say that there are all kind of ways to look at appropriateness, and you're giving me way too much credit for the appropriateness criteria, by the way. But in this month's JACC intervention, I've taken a shot at considering two directions. One is from the ACC, the appropriateness criteria, which creates categories, right? Categories by which you can guide things. And I notice you have on the wall your appropriateness criteria so that you can help make sure that you're going by those guidelines. The other approach, which is more common in the European system, is the heart team approach, right? For the complex cases, whereby you bring in opinions of the non-invasive cardiologist, the interventional cardiologist, the surgeon, and the patient, all to think together. I don't think these are mutually exclusive, but they come in a little different direction. And I think the heart team question focuses a little bit on the appropriateness criteria, because in those categories, as you probably will agree, there are sometimes exceptions.
Yes.
And it helps you think through the process. So this case you've got, I'm looking at, and I'm fascinated to learn. You ask how I always start thinking about cases. I want to know what's the problem with this patient.
Right.
Why is this patient here?
Yeah, this patient, that's a very interesting. He presented in May, has a new onset of dyspnea and Canadian Class II, had a CTA revealing 3-vessel disease, and with a high calcium score. Then they did a stress nuclear, which showed moderate lateral wall ischemia. And at that time, he had a Cath 3-vessel with a syntax score of 30. As you mentioned, at our center, 23 and above, patient comes out. We get a heart team discussion. because not the carrying the surgeon while patient on the table. We have the rule in the past used to be 33 and above. Now it's of 23, knowing the data of 4-year follow-up of the syntax, and patient was recommended CABG because of the high syntax score, although one vessel was totally occluded, which is the obtuse marginal. With that note, the patient actually proceeded. We brought the patient back in the room and then tried to do intervention of the circumflex. That OM was closed, large OM. We dissected it, we left it, and then put multiple stent in the right coronary artery, 3 of them, which is the Promus Element, and which looks very good. Now he is on medication. He has now, his symptoms are slightly lower than before, but it still continues. He is not without symptoms, and the young guy, he wants to do everything. So we have not repeated the stress test, and we only concerned here was the LAD lesion, which clearly looks both in the proximal and mid LAD. Proximal lesion calcific. Idea is that because of symptoms are coming from either from OM or is from the LAD, so that patient is here for the interrogation with the FFR guidance.
We would call this right now stable.
Is the patient now is stable?
Ischemic heart disease.
Yeah, even last time it was stable. It was just based on the stress test and the positive CTA.
Okay, so we have stable ischemic heart disease. We have we know the anatomy uniquely because previous intervention and previous Cath, and we know we do not have a current stress test.
Right.
So absent a current stress test, we should establish that putting a stent is actually going to solve some problem and it's going to eliminate these symptoms, because that's what you're going for right now.
Absolutely, yeah.
Getting rid of symptoms.
And particularly that if we put into our grid in this, knowing that now is a class 1 angina, and this always comes issue where your multi-vessel disease, a patient has class 3, you have taken care of the culprit vessel, you bring for stage intervention for whatever region, and now the patient is asymptomatic. Now the guideline is not very clear. Do you take the symptoms from the time 0? With that time decision was made for multi-vessel PCI revascularization rather than surgery, or we also know that no insurance company will approve repeat stress tests in between. The ACC and CDR became part of it. They are very clear. They say that when patient comes back, the symptoms has to be on that day during that presentation, not the first presentation of the patient's symptoms, to qualify for the appropriateness. Yeah. Although stress test of the original one is accountable, is counted.
Yeah, so I'm not so concerned about the insurance company, nor actually the appropriateness criteria. I think will gradually get tweaked as we learn more and more. But here you have a situation where you've got a symptomatic patient on, you haven't asked about medical therapy, but you have on a lot of therapy, and the patient's still having symptoms, and you have a lesion that may be producing those symptoms. It's perfectly rational to apply a therapy to get rid of those symptoms. That's what we're going for. This is not, we have no evidence about survival in this particular situation. So in order to solve that, either you do a stress test with a flow study, with perfusion, or you document that this lesion in fact is flow limiting. And so if you do that, then you've got a good chance that the symptoms go away. If you don't do that, the symptoms are going to stay and you've done nothing.
That's absolutely is the hem and crux of the discussion today. With the Anu is ready to put a FFR wire in this particular case, and this is exactly what we are going to do. And we'll talk about the role of FFR during PCI and the plaque modification devices. And of course, the FFR, that's very simple. It under hyperemia takes the gradient from pre and post across the lesion, and it's independent of the microvasculature by and large. Of course, there are some pitfalls which I'll allude later. And the criteria for significant stenosis is equal to or less than 0.8. Now we actually have the St. Jude's FFR, the pressure wire, which is now the cordless, so that's much easier. But again, the wires are not that easy compared to our regular 014
high torque, or so it is still required little tweaking compared to our regular wires, which can go very easily.
Okay.
Although, what do you say, the wire has improved in terms of torqueability, or still about the same level?
It's the same. Very difficult to torque. The tip is not that easy to manipulate. That's the only time I think I use the torquer.
Okay, so now you equalize.
Now we equalize.
Anu, how does this wire compare with the rotor wire?
That's a good comparison.
Yeah, good comparison, but still I think probably around same.
See, if you ever start complaining about the wire, then I'll remind you about the rotor wire.
Yeah, but FFR we are using a lot now.
Yes, a lot more. That is true. Spencer, what are you seeing the trend around the country? A lot more FFR?
You know, I asked industry recently, because I was in Japan with Dr. Narula just this last few days, and I was talking about IVUS and FFR. So I did inquire of industry in the U.S. how much FFR. The answer I got was 14%. Now, that's one industry source opinion. So if you'll remember, this is where we all started with angioplasty in the original days, was measuring the gradient.
Yep.
So going back to it is not a brand new thing, but measuring it with maximum hyperemia is a new thing, and it's I think vastly underutilized, if you want my opinion. And I think the FAME trial helped us there. We're about to hear about FAME 2, which will be extremely interesting. As you know, it was stopped early, but that trial guiding the procedures with FFR, comparing medical therapy to intervention, will be reported at the ESC meeting in Munich, and is going to be quite interesting for us to learn some things there. But
when we started 140 microgram per kilogram per minute of IV adenosine.
So this is an important issue. You know, some people are using intracoronary. You're going with the gold standard of intravenous
central line.
Yeah,
forefront. Femoral vein. Yeah.
So this, if you don't do intravenous, then you have to make sure that the real high dose intracoronary is utilized.
Spencer, what do you advocate?
I think the intravenous is the gold standard. Yes, absolutely.
Because it also helps you, we know that once it is positive, it takes 2 to 3 minutes, and then you can stop it if you need to do for multiple lesions. While we are waiting, we are just to the 1 minute. So let me take you a little bit more into these data, which partly Dr. King has said already in terms of the FAME trial data.
Samin, before you go there, let me put you on the spot. What is your estimate? How much would the FFR?
Oh, this will be positive.
Okay.
Yeah, because very angiographically, and you can see here, we can show the
hemodynamics is being shown.
Yeah.
So now what we can do is, when you have maximum hyperemia, you want to do the pullback?
Okay, yeah, pullback. Now
we're going to do the pullback.
Yeah, continue.
So
the question is, there were 2 lesions.
So we are
which one is causing the problem?
This is now at the, so you see the transducer is at the proximal portion of the dark. See that? You should take a picture.
Yep.
So this is another important issue. You can't do this pullback with intracoronary very well.
Exactly.
It's too short acting. So you have to.
So it's still 0.79.
So both lesions are significant. You can see here.
I take it out.
Yeah. Good. Okay, now with that note, let me just quickly go on various data. Tremendous amount of data has been put in the literature. One point, actually, there were few papers earlier for adequacy of the post stenting that get FFR of 0.94. That was initially done by Japanese group, and so. But I think very little people do that adequacy of stenting by the FFR. Basically, for adequacy of stenting, we do it by the intravascular ultrasound if you need to do. Spencer, your opinion on that? Post?
Yeah, I mean, there are many things with stenting. Either IVUS or OCT now is also helpful, perhaps. All the data we have, though, about stenting comes from IVUS as far as optimal stent deployment. So the FFR is going to normalize almost always with putting a stent, rather whether you've got it adequately deployed or not. So that doesn't really answer your question.
That's absolutely correct. Now, remember, the whole concept started in 3 phases. One, that what do you do with a significant lesion? You do a PCI if your FFR is low, or if FFR is high, which is more than 0.75 in the original DEFR study, then it became 0.8. And that's the really data we have, that if you have a high FFR or basically that more than 0.75 and you did a PCI, what are the outcomes? If it is less than 0.75, of course we know that you do better. And this is published in JAC a few years ago, basically puts it here, that if your FFR is more than 0.75 and you defer, at 5 years, death and MI is 3.3%. But if you did a PCI of the FFR of more than 0.75, your death and MI is 7.9. Now reference is because these are the more critical lesion, more tighter lesion, and it's that those have the FFR of less than 0.75. But the key difference is between two. Deferent performance that twice the number in terms of the death and MI at 5 years, and of course these are the stenosis. Then we led to the second one, FAME trial, multi-vessel, where there was no clear-cut stress test, 40 to 70% lesion, and then they went with the IVUS guided or FFR guided PCI. And idea was in the PCI group that if your FFR, you go through each lesion like we did today, that if the lesion has FFR of more than 0.8, then you don't do the stent. If it is less than 0.8, you do stent in every lesion in the FFR guidance. In angio guidance, every lesion which you felt obstructive, get the stent, and of course we know very well the results: improved outcome, decreased cost, lower contrast use, and similar procedural time, and of course saving the money. More importantly, the major endpoint of the death MI, and you follow it for the 2 years, even remain consistent. The death MI, repeat revascularization, lower in patients with the FFR guided group compared to angiography group. So that it becomes overall the gold standard now, that in cases with a multi-vessel disease you want to avoid a stent, it's perfectly fine. If it is more than 0.8, that's that you'll not pay the price. And of course where the FFR goes in terms of the lesion morphology, this is a very nice paper from the same group by Tonino, that if you have a very tight lesion, chances your FFR will be less than 0.8. The tight lesion basically means the 90%, it's almost 95% you'll have FFR of less than 0.8. If it is 70 to 90, the chances will be almost 60%. But once you go to a lower, FFR positivity definitely will be much lower. And also what actually have come, that many times we see angiographically 3-vessel disease and 2-vessel disease, but if you do FFR and there is no lesion and FFR more than 0.8, you can downgrade, so much so that many of the 2 and 3-vessel disease became no vessel disease if you go with the FFR criteria in the FAME trial as shown by this subsequent paper. And then the issue then comes is, of course, similarly will be the data with the syntax, but this is the most important, in my opinion, the piece of information. That is that the lesion which you did not do FFR, and those were the 513 lesions, had a FFR of 0.8, angiographically felt that was significant. What happened to these patients at 2 years? And this is a very interesting. You can see here there were 9 late MI and 53 repeat revascularization. Of the 9 late MI, 1 was due to the deferred lesion. Overall 0.2%, and 8 were the stent related or due to a new lesion. So basically stating that FFR, deferring FFR was safe, and of course we know the event rate in the angiographic arm but much higher. But the key is that by deferring the FFR of 0.8, you do not pay the price of the death and MI at follow-up, and of course most cost effective and from the quality of life the best strategy which we have. And this actually has incorporated in the guidelines now in the ACC AHA, which I have put here. The many times that FFR will be negative despite the tight lesions, and many of the regions are written here. If your connections are correct, it could be just because lesion is not tight, it's eccentric, it's not flow limiting, there is an extensive collateral, and also has been enough data that patient with acute MI setting, that FFR is not correct, has not been evaluated. Very important, acute phase of ST elevation, FFR does not tell us many times what is going on with the patient. That led to the second concept, that what if your FFR is less than 0.8? Can you manage these patients on medical therapy? And that is what Dr. King alluded, the FAME2 trial, which was supposed to the multi-center trial with using 1600 patients, with FFR of less than 0.8 and optimal medical therapy alone, and the patients with a less than 0.8 do optimal medical therapy or PCI plus optimal medical therapy. As you saw that the trial was prematurely halted and briefly was presented in the Euro PCR, more extensively presented next month. But I just wanted to share with you that if you take a randomized trial, that if your FFR was less than 0.8, the PCI medical therapy versus medical therapy, or if FFR was more than 0.8, what were the data? You can see here that if the urgent revascularization 6% less than 0.8 FFR, and at the 9 months follow-up, you have 6% urgent revascularization and 12% total revascularization, while that number was 0.6 and 1.7% if you have they did a PCI, and this number was similar to if your FFR was more than 0.8 and nothing was done. So clearly very interesting observation. So we know who can be deferred, we know who should be treated, and thirdly we know that where the PCI will make a difference in these patients, and so of course it will come a little more in the next month. So just very quickly about the plaque modification strategy of having an angiosculpt or a flextome cutting balloon, basically for the mild to inelastic lesion or mild calcific or rotablation in a heavily calcific lesion, and these are the various mechanisms, basically scoring the plaque by using the atherotomy techniques and the rotational atherectomy by ablating the plaque, and of course issue remain the slow flow and perforation with these devices. But in the calcific lesion, this is the only device and shown to be beneficial. Of course, various complications we need to be careful. And of course, the stent expansion in the calcific lesion is very important. Very important, just want to give historical background that all the trials of restenosis with the rota have not been have failed. So much so the recent data, these are actually the data at Mount Sinai in terms of acute complication, that by various technique we do rota in about 6 to 9% of cases, and about the overall complication rate is just about less than 1%. But more important is that there is a randomized trial, Rotaxis with a drug-eluting stent, paclitaxel with a PTCA versus rota, shown that various groups were comparable, but clearly the answer basically was that by in-hospital outcome, that by using the rotablation you have a better success, less crossover, so acute results were better. But if you go to the complications, there was no difference of the 9-month follow-up, but also the primary endpoint was late loss. The rotational atherectomy caused higher late loss even with the DES. So therefore, this is the device only for calcific lesion for the acute gain, and this is where we should be using in this case. In this case is a quite calcified, you can see here. Anu is ready with the 1.75 bar.
So this is a lesion that clearly needs to be treated to help the patient get over it. The question of whether you need rotablator or whether you don't need rotablator is going to be one that's going to be very opinion driven, because the data is not entirely clear. And I will point you to an upcoming article in JACC Intervention. There is another randomized trial that's going to be reported that's reflects a little bit what you've heard before, and raises the question of whether rotary ablation is helpful, except for patients where you cannot cross the lesion. You cannot get across it, and clearly it is there. But this is, it's like so many things. There operators who are comfortable with one technique may not be comfortable with another. And so I think that just like a baseball player, you might have one bat or another that works.
Anu, 175 bar?
Yeah, this is a 175 bar.
Yeah, this is, again, see that now, I think clearly that even without the cardiac cycle, you see the wall, the calcium in the both segments of the wall. So proximal lesion is more calcified. Lower one is just probably second lesion is just on the one side of the wall, and this is a 1.75 bar, goes through 6 French, little aggressive, but we'll see whether it's a very short lesion.
But I will point out that the expertise in using rotablator is being demonstrated here, because so many people move way too fast with the rotary ablation, and here we see it being done absolutely correctly with slow pecking type movements.
slow packing. What do you think? Should we downgrade?
Yeah, we haven't done yet.
Okay, we'll try. And usually it's a slow speed, 150,000 RPM.
155.
155 and so. Each time 20 seconds and yeah, Spencer, what is the incidence of rota in your practice? Ours is about 8 to 9% consistently for last few years now.
Yeah, it's lower than that currently in my hospital, but this is, once again, it's very, very dependent on your ability to use it, how you use it, how expert you are at using it, and so forth. Once again, I think we just don't know. I think for people who don't use it a lot, it's probably not as necessary as we used to think in terms of long-term results. As you pointed out, you get a little bit better stent deployment, but the stents have become so good that it may not be as necessary as it used to be.
So, Spencer, for less calcified lesions or for a kind of a replacement, are you using the angiosculpt, some cutting balloon?
Oh, I think some people are using cutting balloon a bit. I do think so. You know, one of the things we used to use a lot when using IVUS and try to determine whether the calcium was concentric or not, you know, so that we could predict whether the artery would dilate adequately. What we used to call the French method, or the poor man's rotary ablation, was balloon dilatation first, and if the balloon would dilate at modest pressure, then and the constraint on the balloon would be eliminated at modest pressure, then the rotary ablation would be avoided. And if the lesion did not open, then you would resort to rotary ablation or scoring or something like that. So I think this is one of the things that there's no absolute. There are a lot of absolute rules about being made about who should be done, who shouldn't be done. There are exceptions to all of those, but when you get down to the technique, you have to do the technique that the operators do, they're comfortable with, and are expert at. So I think there are many, many ways to approach this lesion, and we're seeing it done expertly here.
Spencer,
what we did actually change to a 1.5 burr.
Okay.
If you see that with the proximal lesion, you see the moderate calcium on both sides of the wall, and the second lesion actually you see it on one side of the wall. The thing is, we could have gone maybe another minute more with the same burr size, trying to do the rotational atherectomy, but we just downgraded. So the rule is the same, is maybe you can use the same burr, go up to 3 minutes to see if you can have good rotational atherectomy at that particular area. Now we're just going to check the speed again and see that what's the speed for this. We went to 1.5 now. Good.
Yeah,
about
and actually
160.
The reason was he started having cough actually. I've seen some patients,
Hiccups.
more importantly hiccups actually, and there was some ST elevation, so that you are having a no headway using this big burr, and clearly that burr was, we know that our goal is just to shave that calcific part of atheroma and rest with the high pressure balloon dilatation. We are going to open this up. So that
Samin, there is a question for you, that at this stage would you have considered just putting in a non-compliant balloon?
Well, I think the goal still remains the same, that I strongly believe in this particular case that you need a rotational atherectomy to have your good results in stent expansion.
Yeah.
So, but otherwise also, yes, many people can do, keep it quick, yeah, that many people will do same, that you another wire with a non-compliant balloon, and whether the cutting balloon or flextome or angiosculpt will go and will do the open the lesion. I'm a little skeptical So I can tell you the most of the time, anytime I thought that I should do rota and I did not do rota, I had a more trouble compared to doing the rota, because rota bails you out. In this kind of case will not be some cases that even you can see with this bar that area of the proximal LAD is still very tough to go through.
Let me ask you a question that doesn't apply to this case so much, but if this had been the right coronary, would you use pacing as part of the procedure, or
Yes.
always?
Only for the right corner.
Only for the right.
Yeah, we actually do because if we need to avoid for some reason because of the venous issue, then we give aminoflin and atropine. But like one lesion has been done, but on the right coronary, and we actually have seen sometimes asystole with the left main also. So those are the two situations when we will put a pacemaker.
So now the first
excellent demonstration there. I think the downsizing was a great idea, and it's proven exactly what you were wanting to do.
Yeah.
Through the first lesion already, are
we are
planning
through
to
the
go?
first lesion. I did a polishing run. Now is the same. How do you go to the second lesion?
Right.
Is same. You go all the way to the second lesion, and now you start burring again. And when you stop at the second lesion after 20 seconds, you don't have to come all the way back to the proximal LAD. You can come back to the in-between area and wait. See, you come back to the in-between area, wait, and then do one more polishing run.
You obviously understand this so well, but some people using rotary ablation are totally confused about it. This demonstrates so well. It's a sanding operation. You're sanding the lesion, so there's no way that you can do that without being on the lesion, dwelling on the lesion. Popping in and out is counterproductive and doesn't achieve the result. So this is a beautiful demonstration of how, if you're going to use rotary ablation, this is how you do it.
Okay, we are coming out now.
Spencer, it has been just a pleasure benefiting from your wise words. I want to engage you a little more in the appropriateness criteria, since we get so many questions about it. There are two ways I think of looking at it. It's a beautiful combination of guidelines, clinical trial evidence of our clinical expertise. Yet there have been these draconian administrative actions of the CMS, and hospitals and doctors are getting a double whammy between the CMS actions and the rationing by HMOs. How do you see it all? Where is the balance which only a Spencer King can give us?
That's it.
Well, I'm a bit under the gun because, as you know, we did publish the results from here in New York State regarding the adherence to these appropriateness criteria. The criteria, I think, are not perfect. Let me start with that. They are an attempt. They're the best attempt so far to try to create categories where rational thought would be, if you had this kind of situation, this is what you would do. So I have two concerns as to why there's such a inappropriate, quote, inappropriate use in New York State, which turned out to be 14% in the study we did. But the fact that it ranged so widely among hospitals, this being one of the lowest, I can tell you, is perhaps a problem of inappropriate use, or perhaps it's a problem of inappropriate data entry. Because given these categories and the requirements for the medical therapy and the demonstration of ischemia and so forth, how that data goes in to reflect what is the true good practice is not a pure science. So I think we've got a long way to go to make this, to improve this. So to take this at the point of view of insurance companies or others, I think is way premature. I think this is an attempt at medicine to study what we're doing and try to improve our outcomes. But these are not the pronouncements coming down from the mountain as commandments. These are attempts to improve the what we do by trying to categorize, document, and figure out how we do things. I would overlay in all cases the kind of heart team approach. That is the idea that what is the reasonable person going to think about this? Not just the reasonable operator whose tendency might be to, okay, I need to do something, but the reasonable input from other physicians and in many cases from surgeons to try to understand what should be done. So the appropriateness criteria, I think the major benefit of this is an attempt to look at what we're doing and to be critical of ourselves. And if we do that, we're going to improve the system. But the appropriateness criteria is going to change over time. It's going to improve and become more precise.
So maybe perhaps even individual interventional cardiologist should really not review it as a judgment on his, but to probably use it proactively to maybe do things a little better?
I think it's a great guide to put down and say, okay, here's what I think should be done. Does it fit the appropriateness criteria? If it does, fine. If it does not, then why not? What is my rationale? And be able to defend that. If you can, then you've got a good thought process that's going to help move things forward.
Samin, back to the case, you put in a balloon ready to stent now?
We're going to just say it. Let me complete this. What Spencer said about the appropriateness, that's just a guide. Point is, at least what I defend on, as you saw in our symposium, I debated Dearstein, who was part with Marceau, Jack intervention about inappropriateness of the appropriateness criteria. But at least for the general interventionalist, we actually didn't have any rules, what to do, not to do. At least this gives you some guidelines. Some cases still will fall outside the guideline, but you have to be able to defend them. And clearly there is so much variation. With this, the understanding of the criteria and putting some rules, regulations will do that inappropriate will decrease. Because right now, just in the New York State, our JAC paper, it was 3.5 lowest being Sinai and highest was 49. So there was so much variation.
Don't say who that was.
Yeah, that they don't say, but that's okay. But key is just so much variation. And the similar data from North Carolina, similar from ACC and CDR. So therefore some inappropriate use will occur, but it to a very small if you are really careful about what you are doing, because we know many things they're not in the guidelines, but we need to do it because of clinical scenario.
But if you think about it, the inappropriate things that have gotten people in trouble are not that obscure.
Yes.
They're pretty obvious to everybody that should not be done.
That's it.
And there is some of that out there, so that we all should be very cautious and make sure that we're not doing.
Good.
So if you can just see, we took a 275 15 balloon. We took a 15 balloon. We knew the lesion, second lesion is long. So, but the proximal lesion was shorter. That's why we went with the
quantum apex.
Yeah. So if you see the second lesion expanded well, if you see the first lesion, just right, this is a good expansion right here. You see how the calcium is not letting the complete expansion of the balloon. This was at 16 atmosphere high pressure balloon. So we have a stent ready to go now. We have a 3032 Promus element to go to the second lesion. No, we'll get the rotor thing there.
Yep, good.
So I will ask you the question about this specific patient. So the first time around, this LAD was not treated.
Right.
And that was because you weren't clear that this was ischemic then?
No, basically that we knew that all the lesions, right coronary and OM was total.
Yeah.
Right coronary was multiple lesions, 90+%,
Exactly.
angiographically.
Yeah.
So those are the one we did with the 3 stents, a bifurcating lesion of the right coronary. So that we did a OM, which was failed. Only we were able to get subintimal channel, but did open, which looks much better now, and we'll probably put a stent later today offline. And then we felt that now bring the patient back. If we would have been a completely asymptomatic, probably would have left it.
Yeah, so this is
Yeah.
not really a staged procedure. This is a procedure treating what you thought you knew was a problem.
Right.
And then angina continues.
Yes.
And so now you're treating the residual problem that's producing the angina.
Right, and again, that angiographically we were not sure, and we felt that the FFR will be the right tool. So that this is the kind of teaching, educating our audience that once you bring back patient for stage intervention, unless it's a 90+% angiographic lesion, the best your defense is, or actually the right thing to do, I would say, is that to document that that lesion was causing symptoms. Clearly, that many times your FFR is negative, probably the lesion is not causing any problem. Therefore, you have a FFR of less than 0.8, I would say it will also signify that likely was the cause of the patient's symptom.
Yeah, I would point out that there is a situation of FFR being positive, yet not causing any symptoms, because there are people who can never achieve maximum flow. You know, they are disabled, they're quite elderly, they have, you know, there's no way they're going to increase their flow 3 or 4 times. So the fact that you can prove a positive FFR doesn't automatically mean you have to do something to the lesion.
That looks excellent there. Good stent expansion, angiographically perfect.
Safe.
Spencer, just shifting gears, any role of bare metal stents in, have you used a bare metal stent in 2012?
Sure, sure, but not in this case.
Yes.
You've got a long lesion, you got LAD, you got multiple lesions. No, you need a drug-eluting stent here.
Where are you using bare metal stents?
Primarily in acute infarction, and this is controversial, but in large vessels with STEMI, particularly in the setting of not knowing what the compliance of the patient might be with dual antiplatelet therapy and that sort of thing. Given the relatively low differential between the most current bare metal stents and drug-eluting stents, in STEMI, I think it's not unreasonable to use it there. In very large vessels with short lesions, the differential in restenosis is very small, so it might also be okay. Having said all that, you know, drug-eluting stents have by and large taken over, and one of the main reasons is the differential in price. You know, if you look at this in some markets, particularly in China, where we were talking recently, I said, yeah, they use 100% drug-eluting stents, and I said, well, that's interesting. What's the difference in cost? They said zero.
Yep.
Zero difference. Well, so it's a big driver of bare metal stents some years ago was a tripling of the cost for the stent. So these are all important factors. I think the most critical thing that we've learned recently is that the second generation drug-eluting stents, the newest drug-eluting stents, appear to have a very, very low late thrombosis rate. Not zero, but very low, and much more reassuring than we had been worried about originally.
Now, one very the technical point here, that you see the first lesion, when we put a stent, the diagonal is there. It was always about 30% ostial, nothing significant. Now maybe looks about 50 after ROTA and PTCA. And I think this will be a good question, that should we wire it, protect, not necessarily you do a PTCA or so, but should you wire it when you're putting a stent? Would you wire in your practice?
This particular one, I would not.
Okay. Well, Anu said no also, but I said we wired it. I forced her to wire. Now let's say, go.
Yeah, I can see you wired it.
Yeah.
That's why I said no, just to give you some.
Samin, there's another question for you which has come. What is the role of FFR post stent?
Well, I try to elude that a little bit. I would say ignore it. The FFR does not have any role. If you want to do something post, it has to be the IVUS.
Spencer, same thoughts?
Yes, no, the FFR is going to be normal after the stenting. And even if the stenting is not optimal, the FFR will be okay.
I know.
So I think the big, if you're going to do anything after stenting if you're worried about the deployment and so forth, then either IVUS or OCT are
3.25.
are the measures that we should be doing.
Spencer, where is OCT going to fit in our practice?
It's going to fit prominently, I think. I think the OCT perhaps coupled with pressure measurement and all kind of things, the technologies are going to continue, but the big problem with OCT right now is we need to learn what it means. We see more with OCT about the endothelium than we've ever seen before. We see small dissections. You do a stenting like this, you may see a tiny edge dissection. You may see tissue extrusion through the stent. What do you do about that? We don't really know, because all our information comes from angiographic and IVUS, and so but the fact that we don't know doesn't mean it's not there, and it doesn't mean it may be in some way relevant. So I think I think OCT has a great future.
Okay, now we're just coming back to the end of it. As you can see here, that the Promus element actually the balloon is not exactly the semi-compliant, so that you can go up to 14 or 16 atmosphere. Compared to with our Zions, we don't go beyond 12 because of edge dissection. Now see here that excellent results. There is a little bit of narrowing at the area just after the diagonal in the proximal part. The second looks very nice with the PTCA, and the Promus element is a 3032 distally, and it's a 3.520 proximally. All the branches are intact, and this is what the beauty of the second generation stents are, that all the branches remain quite intact. So that from interventional perspective, I think in this complex case, we were able to achieve and what we needed to do. Of course, we might do a little post dilatation and so, and knowing that it has been a complex procedure, I probably will leave that OM alone for the time being and may decide later, because I think we had taken care of the ischemia producing vessel based on the FFR. Both lesions were significant, and therefore I'll just quickly end our presentation with that FFR now has emerged as an invaluable tool to identify lesions who should undergo PCI and who can safely be deferred. That's the very important, that now the prognostic value IVUS has been, but there is truly in the DS era, there is no trial of the IVUS shows that yes, by doing IVUS maybe in the left main, yes, that too was not a randomized trial from Park, that by doing the IVUS you improve the outcome. Here we know FFR less than 0.8, if you don't do PCI, even your maximum medical therapy, patient will have a repeat revascularization. I still believe that FAME2 trial, they prematurely ended, because still will not give us a final answer. If they would have continued a longer follow-up and more number of patients, maybe we would have seen some trend, and though they have not been presented.
I'm with you on that.
Yeah.
I mean, without a mortality difference, we should have, they should have continued. Yeah. But I haven't seen the data. Yep. The data will be presented, as I said, in Munich, and maybe we'll be surprised. I'll be interested to see that.
Yeah, I know, at least am I. Then the second point of the plaque modification strategy, using rotational atherectomy only in the calcific lesions, heavily calcified. It does not have any impact on the long-term outcomes and restenosis. With that note, as I mentioned, that we'll have 5 questions related to our presentation. That is, the role of FFR has been studied in the following studies, except DEFER, FAME, Syntax, and FAME2. The second is, what is the appropriate dose of IV adenosine for hyperemic FFR evaluation? 140, 160, 120, 200, and 100. The third, the FAME trial at 1 year showed the following outcome in the FFR guided PCI versus angio guided: reduced contrast use, lower stent use, reduced mortality, and lower TLR. The fourth question, in the Rotax trial of rotablation and stent, which drug-eluting stent was used? Sirolimus-eluting stent, paclitaxel-eluting stent, everolimus, or zoterolimous? And the last, fifth question, following which following feature best describe the role of rotational atherectomy in plaque modification in calcified lesion? Lesion facilitation and stent expansion, lower restenosis, lower late loss, and lower long-term mortality. I'm sure these all questions are very simple, very pertinent, and with my team and of course our fellows, 2 intervention fellows here, Dr. Narayanan and Dr. Papi, with my team, Vicky, Nurse Pablo, the CVT, and of course our Mount Sinai audio the Mount Sinai TV and audiovisual guy and his team has done a tremendous job getting patient ready, broadcast appropriately, and show all the elements of the complex case as we demonstrated in this particular case.
Samin, excellent. These questions are going to be posted on the website.
Yes.
Spencer, final words from you. Anything we need to improve? You think we have a good format here which is consistent with the goals of education from the college?
Listen, I think the success has been documented by the voting of the clicks from the people who watch this program. I think the addition of the college to help either even further improve your effort is going to be exciting. There's no question. I travel a lot, so there are many places in the world I think are very appreciative of this kind of input, and I could see in the future, if I reflect on Fareed Zakaria's approach to the post-American world, that we're going to hear a lot coming back the other way. We're going to hear a lot of input from other places also coming for us to help us learn. So the world is coming together, and we're going to see a great deal of interaction, and the only way we can do it is electronically. We can't burn that much fuel flying everywhere. So this is a great technique, and I congratulate you on teaming up with the college to do it.
Anu, final words from you.
I think we have demonstrated, technically how this, I would say, moderately complex case could have been done. The question always was the same: was rotational atherectomy important in this case? The fact that 175 burr could not go through the lesion, we needed a 15 burr, tells us that was an undilatable calcific lesion. If we were there just going with the PTCA or cutting balloon, we would have had, you can still see in this picture that there was a dissection after rota and PTCA. If we had just gone with cutting balloon or PTCA, we would have had a longer area of dissection. But we were able to come out with the planned strategy of 2 stents, able to cover what we wanted to cover, not with a full metal jacket, and all the side branch patent. So this was we were able to do because of rotational atherectomy, and I think we were able to just demonstrate the fine skills how to do rota slow packing motion, which has been shown here. We have a new group of fellows with us now. For right now we have 9 interventional fellows, but 3 non-ACGME, but 7 ACGME. I have Rajiv here, who is an ACGME fellow from Mount Sinai, full training from Mount Sinai. I have Rajiv Papi here, who is also another ACGME fellow who have just started. We have the others who are working in the other room. The goal is not even training the globe, but our fellows also who will be fully skilled by the end of 1 year to do all these complex cases. Thank you.
Right.
Anu,
Okay.
great case, terrific teaching points. Good luck to your fellows. Also, I greatly appreciate Dr. King's participation today, an absolute founding pillar of the college. It has been wonderful benefiting from his deep intellect. Please watch also our peripheral interventions, July 25th, and we'll see you for our next webcast on August the 21st. Till then, you can always go back and watch the archived session, watch the questions, keep sending our feedback, and we'll see you next time.